I am Aaron Waxman. I am the Executive Director of the Center for Pulmonary Heart Disease and the Director of the Pulmonary Vascular Disease Program at the Brigham and Women's Hospital and an Associate Professor of Medicine at Harvard Medical School. I'm going to be talking to you about hemodynamic monitoring. Relevant to today's talk, I have no conflicts to disclose. I think it's always best to start with what we mean by hemodynamic monitoring, some very simple definitions. Hemodynamic monitoring is based on both the non-invasive and invasive measurements of features of physiology. Specifically, we're often thinking about systemic arterial pressure, central venous pressure, pulmonary arterial pressure, and really most importantly, cardiac output or stroke volume. The reason we strive for good hemodynamic monitoring is because we're really trying to sort out organ perfusion. And so far, we really do not have a way of directly measuring how well we're perfusing the vital organs. We also make some assumptions, most importantly that pressure reflects volume. And you can see a number of aspects of that here where we talk about right ventricular preload and left ventricular preload. And I think importantly, we have to ask ourselves, how are we supposed to be using hemodynamic monitoring to best afford good outcomes for our patients? We need to start with a working diagnosis, and that should be based on the relationship between the pressure and the cardiac output or stroke volume. You have to consider conditions that may actually alter the reliability of pressure as an estimate of adequate circulating volumes, and some of those include abnormal pressure-volume relationships, i.e. a poor compliance of the right ventricle or left ventricle. We have to consider increased intrathoracic pressure, such as when patients are mechanically ventilated and on positive end expiratory pressure or auto PEEP, as well as increases in intra-abdominal pressure and how those may affect flow through the thoracic cavity. We also have to consider valvular heart disease, specifically diseases like mitral stenosis. And I think it's really important, before you can truly interpret hemodynamic monitoring, to take a good look at the patient's history. We also have to think about why that patient needs to be monitored, especially in the setting of hypotension. This is just a very simplified approach to why patients might be hypotensive. They could include decreased preload or decreased intravascular volume, myocardial dysfunction, such as what happens in cardiomyopathy or even acute myocardial infarction, and decreased afterload. And there are a number of reasons for decreased afterload. The end result of some of these dysfunctional states include hypovolemia and mechanical obstruction, which are relatively easy things to define. And I think the most important, especially when it comes to good critical care, is the whole concept of vasoplegia. And when patients have vasoplegia, an inability to constrict, the role of hemodynamic monitoring not only becomes more important, but also more difficult and even complicated. Now, we can think about hemodynamic monitoring in two different ways, intermittent versus continuous. And when we think of intermittent, what we're really talking about are static measurements. And those might include things like arterial pressure and mean arterial pressure, central venous pressure, pulmonary artery wedge pressure, heart rate, and urine output, and we'll go over each one of those. The dynamic parameters, which are a little more difficult to obtain, but probably more informative as to the actual perfusion and filling status of the patient, include continuous arterial pressure monitoring, arterial pulse pressure variation, systolic pressure variation, and stroke volume variation. And when we think about those, we can think about the targets, because obviously we're obtaining these measurements so as to adjust whatever we're doing therapeutically for the patient. We can think about each one of these things as being either too fast, too slow in regards to heart rate. If preload, it could be too high or too low. Do we add or do we take away? Afterload, again, too high or too low. Contractility or cardiac squeeze, stroke volume. Here we have to think about approaches to improve ventricular performance, and then central venous oxygen saturation or mixed venous oxygen saturation, which we'll talk about in depth and reflects contractility indirectly. Now, before we can do good, accurate hemodynamic monitoring, we actually need to be able to assure ourselves that the data is good quality. That requires good calibration and an understanding of not only the setup of the system, but calibrating the system. You can see an example of a patient down here, as well as over here, indicating what's called the phlebostatic axis. That's trying to line up our transduction system with the right atrium. And generally it's felt to be in the mid-axillary line in relation to the nipple. We want to make sure the system is properly leveled, properly zeroed to the phlebostatic axis, and make sure that we're eliminating any hydrostatic pressure differences within the catheters that we're using. It's also important to know that this catheter system is not simply an intravenous catheter, but it's a non-compliant manometer line that's actually designed for high-pressure systems. Now, if we start to think about specific components of hemodynamic assessment, we often begin with the mean arterial pressure. Now, the mean arterial pressure is thought to be and felt to be a physiologic estimate of perfusion pressure. The reason we use mean instead of the individual components is that the mean is less subject to variability than systolic pressure is. In fact, if you watch systolic pressure, it can vary beat to beat, where the mean arterial pressure is often much more stable. We generally think of a mean arterial pressure greater than or equal to 65 millimeters of mercury as being in a normal range or an adequate perfusion range. However, it's important to remember that not all patients have normal blood pressures. Those patients who might be chronically hypertensive, untreated hypertension, may actually require a higher mean arterial pressure. Also, in those patients who may have cerebral edema or spinal cord ischemia, we may want higher targeted pressures. Generally, though, optimal blood flow into the vital organs is achieved first by maintaining adequate circulating volume. If we were to increase mean arterial pressure without thinking about inadequate circulating volume, we could actually do harm. Now, this is what an arterial pressure monitor waveform looks like. You can see the characteristic waveform here. We see a very rapid upstroke, which indicates systolic ejection. You can see a dicrotic notch, which is consistent with or correlates with closure of the aortic valve, and then a smooth progressive runoff here, which reflects diastolic runoff. Now, it's important also to remember that the arterial pressure waveform has different shapes depending on where you're monitoring from, and that will also impact the actual pressure readout from the system. That systolic pressure can increase by as much as 20 millimeters of mercury the farther the monitoring site is from the aorta. So that means that you can have quite different readouts from the radial artery versus the femoral artery. Also, the waveform itself may change depending on where you're measuring from. Now, there are significant limitations to following arterial pressure. And again, this gets to thinking about these numbers in relation to the patient. Here's an example of a 58-year-old moderately obese woman who has a history of diabetes, who presents with hours of worsening shortness of breath and delirium. If all we knew was that she had a mild increase in temperature, that her mean arterial pressure was low at 57 millimeters of mercury, she's somewhat tachycardic at 117, white count is normal, hematocrit is low, chest x-ray is clear. Just following mean arterial pressure has significant limitations. In this setting, that number does not inform us what's wrong. It doesn't tell us, is this low because of a heart problem, is it low because of sepsis, or is it low because she's bleeding? How much fluid do we need to give her? Maybe we could follow that heart rate along with the blood pressure, but we're getting limited data. And when should we be thinking about adding blood pressure support, and even think about what is the best pressor to consider? That brings up the next hemodynamic assessment tool, which is central venous pressure. Oftentimes, this is the only parameter that people use to monitor hemodynamics. The real purpose of measuring central venous pressure, or right atrial pressure, is to try to estimate right ventricular end diastolic pressure, which should reflect right ventricular end diastolic volume and be a more accurate assessor of preload. Central venous pressure alone may not differentiate between changes in volume or changes in contractility. And some of that depends on when you're actually measuring central venous pressure relative to the patient's acute presentation. This is what a central venous pressure looks like. We're measuring generally from the right atrium with the catheter or the superior vena cava. You can see the waveform idealized here, where we have an A wave, which reflects atrial contraction. We have a C wave, which is the isovolumic ventricular contraction, forcing the tricuspid valve to bulge into the right atrium. So you get this uptick after that initial down tick from A down and up to C. Then we have the X descent, which is the drop in pressure in the right atrium as the tricuspid valve is pulled away from the atrium during right ventricular ejection. Then that's followed by the V wave, which is the filling of the right atrium during late ventricular systole. And this is followed by the characteristic Y descent, which is that drop in pressure in the right atrium when the tricuspid valve opens and the right atrium empties. Now, the most important aspect of reading a central venous pressure is how we do it. Generally, all of our hemodynamic waveforms should be measured relative to the EKG. And you can see here the P wave, and again, thinking about electricity running faster than the physical transduction of a pressure signal. Here's the P wave, and that should line up with the A wave. Now, the way we assess a mean central venous pressure, we take the peak of the A wave, the bottom of the X descent, and the mean of those two numbers is equal to the central venous pressure. Now, central venous pressure can vary with respiration, and that has direct relevance as to whether our patient is breathing spontaneously or is on positive pressure ventilation with a mechanical ventilator. And those waveforms will be opposite each other. So the patient who's spontaneously breathing, by convention, we measure the central venous pressure at end expiration, when the pressure differential between atmospheric and pulmonary has equalized. It's the exact opposite with positive pressure. Remember, we normally breathe with negative pressure ventilation, and with a mechanical ventilator, we're actually blowing that pressurized air into the lung. So end expiration is actually the opposite. It's the lowest pressure point versus the highest pressure point. These are just two examples of patients who we are measuring central venous pressure. Again, what you can see here is following that P wave, you can see we have an A wave, a C wave, an X descent, and a V wave, and a Y descent. And this is an example of a patient on positive pressure ventilation, where you can see this inspiratory, expiratory phase, and we would generally measure out here at end expiration. Now, an important variable that can be obtained from a central venous pressure monitor is the central venous saturation. And this is important because the determinants of central venous sat, like mixed venous sat, can be approximately defined by a modified Fick equation, which you can see here. The components of this can be very useful in managing our patients. So the central venous saturation is affected by a number of variables, including the hemoglobin. So again, blood volume and oxygen carrying capacity. It's affected by cardiac output, which is really one of the key things we want to be following in these patients. It's also affected by the oxygen saturation, or the percentage of those hemoglobin molecules that are actually bound to oxygen. And the central venous sac can give us some clear ideas about tissue oxygen requirements based on variability of this and the extraction of oxygen. And a normal central venous sac should be around 68 to 75%. So it becomes an important variable when that central venous sac either goes below normal or above normal. So how do we use the central venous sac? Changes in central venous sac should drive us to think about what are the causes of that change. And those causes could be the direct components of central venous sac, such as hemoglobin and bleeding or blood loss, cardiac output or heart failure, oxygen saturation, which might be affected by respiratory failure, and tissue oxygen requirements, which could be increased or decreased depending on that clinical scenario. But it's really important to be able to interpret this number based on the clinical presentation of the patient. And you really need to be thinking about the entire picture of that patient in both their history and the acute presentation. So decreases in central venous sac often mean that there's a decrease in oxygen delivery, i.e. that it's not high enough to meet tissue demands. So if we have inadequate oxygen delivery, that might happen because there's respiratory failure and poor saturation. Patients could be significantly anemic, or there's insufficient cardiac output. It could also be due to increased tissue extraction, which might happen in a patient who's febrile, patient who's shivering. It could happen in thyrotoxicosis, patients who are agitated, or in the setting of exercise. And then there are also circumstances where we can see increases in central venous sac. This could indicate improvement of the previous poor situation, which is a nice aspect of how we follow this over time in patients. It could also be in combination with other findings, such as a rising lactate level, indicative of tissue's inability to extract oxygen. We can see this happening classically in septic shock. We can also see it in features such as cyanide toxicity, carbon monoxide poisoning, or methemoglobinemia, all situations where there's an inability to utilize that oxygen. It could also happen in hypothermia, where metabolism is decreased or even shut down. It could happen in shunt, where oxygenated blood is being shunted into the venous side of the circulation. And also if we drive patients with medications such as inotropes into a high output state. This is an example of how we can use the central venous sac in a clinical situation. This was a patient who was 72 years old at the time of presentation. She came in with a 3-day history of dysuria and new onset confusion. She was febrile, she was tachycardic, she was hypotensive, and also tachypnic. Her lactate was initially measured at 4.3, and you can see at the first arrow on the left at presentation the central venous sac, and then she was resuscitated with normal saline, and over the next 2 hours she received about 5.5 liters of normal saline, and you can see just with normal saline her central venous sac increased into the 80% range. This is a very classic presentation of someone who presented with septic shock that was actually truly volume responsive. Now we can move on to thinking about the pulmonary artery catheter and its uses, which is really, I think, the foundation of what we think of as hemodynamic monitoring. The pulmonary artery catheter can be used to establish diagnoses in very focused situations. In some situations, it can be used to guide therapy. It can also be used to monitor the response to therapy, and I think importantly, it can assess determinants of oxygen delivery. But all of these things need to be taken in context of the patient's presentation. You can see an example of a pulmonary artery catheter down here. Essentially, all it is a hollow tube that is fluid-filled and connected to a transducer. There are various types of pulmonary artery catheters. This one, you can see an electrical connector here, which allows for measurement of cardiac output using thermal dilution. One can also use it simply by drawing a sample of blood and applying the Fick principle to measure cardiac output, assuming or measuring oxygen consumption. Now, this is the information that we actually get from the pulmonary artery catheter. There are directly measured components, including the central venous pressure, the pulmonary artery pressure, the wedge pressure, the cardiac output, and the mixed venous oxygen saturation. As far as the pulmonary capillary wedge pressure, the way that is obtained is you can see an example of a catheter here with a balloon tip on the end. That balloon tip is wedged into a vessel. That essentially creates a static column of fluid that directs back to the left atrium and allows us to indirectly measure left atrial pressure, hence the term pulmonary capillary wedge pressure. Importantly, a number of variables are calculated from those direct pressure measurements. We can get stroke volume and stroke volume index based on cardiac output and heart rate. We can get the cardiac index based on a measured cardiac output and relative to body mass index. We can also calculate the systemic vascular resistance based on flow and pressure differentials. In the same way, we can measure pulmonary vascular resistance, and we can measure oxygen delivery. This is what a catheter looks like on X-ray in 2 different patients. The arrow is pointing to the tip of the catheter. When one places these catheters, generally you just want to make sure that they are not extended too far out into the periphery. Otherwise, they're relatively safe. This is what the pulmonary artery pressure waveform looks like. And you can see we're now measuring with a balloon down. Catheter is out in the distal pulmonary artery. This is the characteristic waveform. You can see the systolic upstroke and peak systolic pressure, the dicrotic notch reflective of closure of the pulmonic valve, and you can see over here the normal range of pressures. Systolic could be anywhere to 15 to 30, and again there's beat-to-beat variability as well as respiratory variability. Diastolic pressure is generally significantly lower than that at 10 to 15 millimeters of mercury, and we generally follow the mean pulmonary artery pressure, which ranges between 10 to 20 millimeters of mercury in the normal range. These are typical pulmonary artery pressure tracings and how we measure them. Generally, we use the same calculation for mean pulmonary artery pressure as we do for mean arterial pressure. That is the systolic pressure plus 2 times the diastolic pressure divided by 3. Just like with the CVP, we measure it relative to the EKG, and things are a little bit further downstream, and this reflects ventricular contraction. So you can see here the QRS should line up with the beginning of the systolic upstroke of the pulmonary artery pressure waveform. This is just another example of pulmonary artery tracing, and this just shows you the effect of an extrasystole here, which results in some decreased filling, which is reflected in the decreased size of the waveform. Now, if we think about the pulmonary capillary waveform, this is very similar to the central venous pressure waveform. In fact, it should look pretty much the same. It's now reflective of a little more delay in time and sometimes a little more impact of respiratory variability because of how we're measuring it. Here you can see that the balloon is inflated on the tip of that catheter, creating that static column of fluid back to the right atrium. The components are exactly the same as what we went over for the central venous pressure. And this is what the waveform looks like, and you can see this significant respiratory variability, but we would use the same convention in a spontaneous breathing patient. We would read it at end expiratory pressure. It's important to be very stringent about how you acquire a pulmonary capillary wedge pressure. You want to make sure that that A wave now lines up with the QT interval, just because we're now talking about a change in timing of the reflection of that wave. But this is probably the most difficult aspect of getting accurate measures. And this just shows you where we would measure that pulmonary capillary wedge pressure at end expiration. Now, there can be differences in how these waveforms look, and they can be reflective of the underlying physiology. Probably one of the more important features of the waveform is what we call the V wave. This V wave in this particular patient reflects an increase in pressure during atrial filling, and it could be due to a number of things. V waves are often thought to reflect mitral regurgitation, but the truth is that a V wave, if it's more than 50% greater in height than the A wave, probably does reflect mitral regurg, but all a V wave really reflects is increased venous return to the left atrium, and that can occur for a number of reasons. Certainly retrograde flow from the mitral regurg itself. It could also reflect decreased atrial compliance and just a stiff wall. But generally, it's thought to reflect increased flow into the right atrium for whatever reason, and it's our job as the clinician to figure out what that reason is. There are a number of things that can make interpretation of the pulmonary capillary wedge pressure difficult. Probably one of the most important aspects of that is what we call over-wedging. And you can see here an example of over-wedging where the balloon is inflated, you start to get an initial waveform that makes sense, and then as you continue to inflate that balloon with the full volume of air, you start to see an increase in wedge pressure. That generally happens because the balloon itself is in a vessel that's probably smaller than we want, and the balloon starts to extend over the tip of the catheter. The simplest approach to getting rid of that is to release some of the air out of that balloon and let the balloon come down, probably reposition that wedge form into a larger vessel, i.e. pull the catheter back just a bit, and you should be able to get a better pressure. But sometimes people don't recognize that and end up measuring a higher than normal wedge. And that's why I say it's really important that you look at the waveform, think about it where it is relative to the EKG, as well as in the context of the physiology. Now, the pulmonary vascular resistance can also tell us a number of things. If we think about changing pulmonary vascular resistance, that could be due to something within the pulmonary vascular circuit itself, like pulmonary arterial hypertension, versus being driven by left-sided heart disease, such as in heart failure preserved ejection fraction. To get at that, we start to think about different changes in the pressure differentials. The first is the thinking of the transpulmonary gradient, which is simply the difference between the mean pulmonary artery pressure and the pulmonary capillary wedge pressure. Normally that should range between 12 to 15 millimeters of mercury. And remember that the pulmonary vascular resistance is calculated by that transpulmonary gradient divided by cardiac output. That just tells us the pulmonary vascular resistance. We want to know, though, is that increased resistance being primarily driven by a primary pulmonary vascular problem or a left-sided heart problem? We can get to that by looking at the diastolic pressure gradient, which is simply the difference between the pulmonary artery diastolic pressure and the pulmonary capillary wedge pressure. Normally, that should be less than 7. Now, I show you a couple of examples here. Over here on the left, this is a measurement in the setting of severe mitral regurgitation, where we see large V waves in a patient with a flailed posterior leaflet and a negative diastolic pressure gradient. In contrast, we have this patient over here who has a measurement in the setting of severe pulmonary arterial hypertension without mitral regurgitation, and here the diastolic pressure gradient is quite high. So those patients who have a diastolic pressure gradient within that range of 7 or less, generally their change in pulmonary vascular resistance or pulmonary artery pressure are being driven by left-sided problems. So if we think about the pulmonary artery catheter and what it tells us, I wanted to show you a couple of examples. This is a 37-year-old moderately obese woman who presents with dyspnea on exertion. She has worsening lower extremity edema and an echocardiographically estimated right ventricular systolic pressure of 72 millimeters of mercury with no mention of the right ventricle. And we could think of 3 different scenarios. One, mild enlargement of the right atrium, a normal LV, And here's her hemodynamics. You can see the right atrial pressure of 11, which is at the upper limits of normal. We can see the right ventricular pressures here, 87. The right ventricular end diastolic pressure is 12. Now, generally, we think of that as the upper limit of normal, just like the right atrium. You can see the pulmonary artery pressure here with a mean pulmonary artery pressure of 48. Remember, we said the upper limit of normal is around 20, and here it's quite elevated. The wedge pressure is 9, which is within normal limits. You can see our transpulmonary gradient here of 39, which is quite elevated relative to that 12 to 15. The central or the mixed venous SAT of 67% is normal. Normal cardiac output, and you can see our calculated pulmonary vascular resistance in Wood's units of 10.8. Normal pulmonary vascular resistance is generally less than 3, but for most people sitting there doing nothing, a normal pulmonary vascular resistance is probably more in the range of 1 to 2. Now we can contrast that. Remember, the echo is the same, but in this case now we have mild enlargement of the left atrium and mild left ventricular hypertrophy. You can see that the right atrial pressure is the same, pulmonary artery is the same, but now the left atrial or pulmonary capillary wedge pressure is significantly elevated. Our transpulmonary gradient is now down, and our resistance is 5.8. The other important aspect here is the diastolic pressure gradient, which is now 7. You can see the pulmonary artery diastolic pressure here of 34 relative to the wedge pressure. And this would suggest then that this is all being driven by heart failure preserved ejection fraction and probably represents secondary remodeling of the pulmonary arterial circuit. And our third scenario is where we have mild enlargement of the left atrium with mild left ventricular hypertrophy. So same as that second. Now you can see some significant differences where the wedge pressure is even higher. The diastolic pressure gradient is lower, in fact negative, and our pulmonary vascular resistance is nearly normal. So this is someone who has almost pure heart failure preserved ejection fraction. I think this illustrates the use of the pulmonary artery catheter probably in its most basic setting, and also illustrates some of the limits of echocardiography. Now, if we want to switch gears to the more dynamic assessment of intravascular volume, we're really thinking about a number of different measurements. We want to think about central venous pressure and how it might change relative to a fluid challenge. We want to think about possibly using ultrasound to look at the inferior vena cava and any changes in the caliber of that vessel in response to breathing as well as fluid challenge. We can think about stroke volume variation and pulse pressure variation, which I'll show you examples of. And then we can also think about using echocardiography to look at dynamic changes in the aortic flow velocity and stroke volume that we can get a hint at from echo. If we first think about the stroke volume variation, and there are commercial monitors that will allow us to do this, we can measure the dynamic parameters of volume responsiveness from the arterial pressure curve. So that area under the curve reflects stroke volume. We can look at the maximal stroke volume, which generally will be at end exhalation. And then we can also look at minimum stroke volume, which would be at end expiration. When we look at that over a 30-second period, we can see a number of cardiac cycles, and we can calculate stroke volume variability based on that stroke volume max minus stroke volume minimum divided by the mean stroke volume. And all of that can be based on an arterial pressure waveform. We could also do it with a pulmonary artery catheter, but I think from the standpoint of truly dynamic parameters, it's easiest to do it off of an arterial pressure waveform. And that degree of variability is reflective of volume status, so that as you start to volume resuscitate a patient, you should see less and less difference between stroke volume max and stroke volume mean, and thus a decrease in the stroke volume variability. The same thing can happen with pulse pressure variation. We can do this off the arterial line. We can also do it off the pulmonary artery catheter, where you can measure the pulse pressure maximum difference versus the pulse pressure minimum difference, and again, calculating pulse pressure variability in the same way of maximum minus the minimum divided by the mean. And this is really a similar parameter to what we just did with stroke volume. And all of these need to be taken in context, and all of them do have some inherent variability. Now, there are a number of things that can limit the ability to get accurate stroke volume assessments. Much of this has to do with respiratory variation and predicting fluid responsiveness. If the patient is spontaneously breathing while mechanically ventilated, and this can also be true when the patient is not intubated, if there are significant efforts on the patient against the mechanical ventilator in the setting of dysynchrony or very high respiratory rate, that can make the data obtained less reliable. Also in the setting of cardiac arrhythmias, such as rapid tachyarrhythmias like atrial fibrillation, atrial flutter, or multifocal atrial tachycardias, those can make these more difficult to interpret. Anything that causes variability in intravascular pressure, such as a mechanical ventilator, especially if you're using some of the less frequently utilized modes, such as a high-frequency ventilator or very low tidal volume vents, even inverse ratio ventilation, which is rarely used today. Those can all impact the variability and the size of the waveforms. Also, if the ratio of heart rate to respiratory rate is low, and in the setting, if you have a very high respiratory rate, the number of cardiac cycles may be too low to get a good assessment of stroke volume variability. The other important consideration is increased intra-abdominal pressure, such as abdominal compartment syndrome. That can very significantly impact stroke volume variability and make those measurements very unreliable. And also in an open chest condition, that changes the intrathoracic hemodynamics significantly. I think it's also important just to remind ourselves about the effects of the mechanical ventilator on hemodynamics. This is variable from patient to patient, but as we increase the intrathoracic pressure, we increase transpulmonary pressures, we increase pleural pressures. That can have a direct effect on decreasing right ventricular preload and increasing right ventricular afterload, which obviously affects not only the filling but the outflow of the right ventricle, which directly affects the filling of the left ventricle. All of these things can impact hemodynamics. I think it's very variable from patient to patient, so it's not necessarily an assumed fact that the ventilator will impact an individual patient's hemodynamics, but this needs to be assessed anytime you're making these kinds of measurements. As an example, both to show you the impact of the mechanical ventilator as well as the ability to use echo to get these same features, you can see here the aortic Doppler velocity time waveform, and you can see the changing here relative to the airway pressure here. As we increase airway pressure by blowing in a breath and then decreasing it, you can see the variability in stroke volume from stroke volume max to stroke volume min, and we're able to get that ratio in that setting. Lastly, I think one of the things we tend to forget about is the ability to measure fluid responsiveness using passive leg raising. Passive leg raising can cause changes in stroke volume that relate to changes in stroke volume induced by approximately 300 cc's of a colloid infusion. This will distinguish those patients who are preload responsive versus those who are not volume responsive in a very simple approach. What you're looking for is to see, as you raise the patient's legs up to 45 degrees, you should see a maximal effect in preload responsiveness within 90 seconds. And you should see about a 10 to 15% increase in stroke volume. If that passive leg raise induced increase in flow is more than 10%, It also predicts that fluid-induced increase in flow by more than 15% with a very good sensitivity and specificity. This is very easy to do in the ICU and very informative, and I think addresses that important question, should we give more fluid or not? So to summarize then, hemodynamic monitoring is based on both invasive and non-invasive measurements that aid in the estimate of the adequacy of tissue perfusion. To interpret the hemodynamic data properly, it is imperative to look at the clinical picture, the whole picture, and combine that information with the data at hand. The proper measurement of hemodynamic waveforms requires correlation with the cardiac cycle, with interpretation of respiratory mechanics, and the overall clinical picture. Relevant to today's talk, I have no conflicts to disclose. Which portion of the ventricular waveform represents the preload state? The choices are systolic peak pressure, beginning of diastole, end diastolic pressure, and the sorry, you want me just
yeah, can you start that over?
Yeah. Which portion of the ventricular waveform represents the preload state? Systolic peak, beginning diastole, end diastolic pressure, or the ventricular upstroke? The answer is end diastolic pressure, which reflects the end of filling of the atrium and also reflects the stretch on the ventricle relative to the Starling curve. Which one of the following statements about central venous oxygen saturation is most correct? Central venous oxygen saturation values less than 60% indicate vulnerable tissue oxygenation. Central venous oxygen saturation values greater than 80% indicate adequate or increased tissue oxygenation. Central venous oxygen saturation values less than 60% indicate low oxygen consumption. Central venous oxygen saturation values greater than 80% indicate increased oxygen consumption. The answer is central venous oxygen saturation values less than 60% indicate vulnerable tissue oxygenation. Which one of the following is the most correct pulmonary capillary wedge pressure value shown in the tracing? A, 35 millimeters of mercury, B, 25 millimeters of mercury, C, 44 millimeters of mercury, D, 38 millimeters of mercury. The answer is 25 millimeters of mercury, and this simply reflects how we measure the mean pulmonary capillary wedge pressure by taking the peak of the A wave and the bottom of the X descent and calculating the mean for those two numbers.